harm in babies whose mothers use progesterone for preterm birth prevention antenatally. Why is the recommendation for daily vaginal progesterone? The EPIC meta-analysis showed that vaginal progesterone reduced the risk of preterm birth before 34 weeks compared with control. Evidence of benefit in reducing preterm birth before 34 weeks was more certain for vaginal progesterone, and evidence for oral progesterone is insufficient to support its use. Overall, a growing body of studies are in agreement in identifying vaginal progesterone as a keystone among the preventive preterm birth strategies in well-defined high-risk categories. Utrogestan, the best choice for pregnancy maintenance. Body-identical progesterone, effective in preventing preterm birth. Safe and targeted delivery to where it is needed more. Trusted by clinicians. Basan Healthcare, innovating for well-being.
Right. Thank you and very welcome.
Sorry.
Sorry.
Panelists, please turn your cameras on. Thank you. Perfect. Thank you, everybody, for joining us tonight, and welcome to tonight's webinar. Before I turn over to our chair, Dr. Lou Pistorius, for tonight, just a couple of housekeeping announcements. First and foremost, as always, the chat has been deactivated for the duration of tonight's webinar. If you have any questions for tonight's panel, please put them into the Q&A and they'll be answered during the Q&A session at the end of the evening. Additionally, if you have any questions for me regarding MedTalk, CPD points, or if you have any technical issues such as audio or video from your end, please also put those to the Q&A and I will answer them as soon as I can. I would like to give a big thank you to MediChallenge for sponsoring tonight's webinar, as well as to Sassuag for also organizing tonight's webinar. And finally, on the issue of CPD points for tonight, if you are a Sassuag member, you'll receive the CPD points for free. If you're not a Sassuag member, you are required to have an active MedTalk subscription in order to receive the CPD points for tonight. For Sassuag members, you just need to have a profile registered on MedTalks, just so we can allocate you the points accurately, as well as upload them to the HPCSA. Now, with that all said and done, I think that's it from me. Allow me to turn over to our chair for the evening, Dr. Lou Pistorius. Over to you.
Right. Thanks, Alex. And you really said all I wanted to say in the introduction, which is firstly to thank MediChallenge for the sponsorship, yourself, and then MedTalks for hosting the series of Sassuag CPD talks. And then, of course, our not one but two speakers tonight, Dr. Samantha Budhram and Dr. Budhram Juleka. So I'll just to introduce you. So I think many of you know Dr. Samantha Budhram very well, a subspecialist in maternal fetal medicine. She completed her undergraduate medical training at the University of Wits, and then specialist training in ONG at the University of KwaZulu-Natal. Then she saw the light and came to Stellenbosch University to subspecialty training in maternal fetal medicine, where she earned her MPhil in 2015. So after a detour back to the KZN, we are now very happy to have her as head clinical unit for maternal fetal medicine in the Department of ONG at Tygerberg Hospital. She's also a senior lecturer in the Faculty of Medicine and Health Sciences at Stellenbosch University. And in addition to being an excellent clinician, her areas of special interest include diabetes in pregnancy and fetal growth restriction, and also undertaking a PhD at Stellenbosch University, focusing on biomarkers in fetal growth restriction. Dr. Budhram Juleka, wave, thanks Budhram. She recently completed her master's degree and training as general ONG specialist at Tygerberg Hospital in Stellenbosch University. and is now pursuing a PhD and working as clinical research fellow. She's principal investigator for the Cervical Assessment Research Study, abbreviated CARE study, which focuses on cervical remodeling and the use of biomarkers to predict spontaneous preterm birth in women presenting with symptoms of preterm labor. So her passion and primary interest is high-risk obstetrics, with a focus on innovative solutions that are responsive and relevant to the unique needs of obstetric patients in low to middle group income group settings. So I can't think of two better speakers for tonight, so stay glued to your seats and eyes wide open, and I'm very happy to pass the baton on to, I'm not sure who's going to start. Proves looks as though you're ready to go. Or Sam, is that you? Anyway, I'll hand over to you. Okay, thanks.
Okay, good evening, everybody. Thank you, Doe, for the very kind words. A special thank you to MediChallenge, the sponsors, for hosting this webinar on a very important topic, and to all the participants that have joined this evening. I think, again, as I did say, very important topic that I'm going to actually kick off with, telling you a little bit about what it is and what is available currently. And I will then hand over to my colleague, Pumsa, who's going to actually tell us a little bit about the research and innovation and what to be looking forward to in the field. So I think if we're going to talk about preterm birth, we need to start off right at the beginning, and obviously what is preterm birth. So preterm birth refers to any birth that occurs before 37 completed weeks of pregnancy. So obviously coming to that diagnosis means that hopefully we do have accurate gestational dating, which can be a problem and a challenge in certain settings, which I shall allude to again later on. So apart from just being preterm birth, it's further defined according to the degree of prematurity, which can actually be calculated based on the gestational age at which birth occurs. So fortunately, the vast majority is moderately preterm birth, which is defined as being between 32 weeks, 0 days, and 36 weeks, 6 days. And then we have very preterm between 28 weeks, 0 days, and 31 weeks, 6 days, which is about 15% of all preterm births. And the least unfortunate for that, although probably that takes up the most amount of resources and is associated with the greatest morbidity and mortality, is extremely preterm birth. And that occurs at less than 28 weeks and 0 days, and roughly occurs in about 5% of all preterm births that occurs. So what do we know about the burden of this disease? So, well, it's difficult to say, and it obviously depends on reporting, and it depends on accurate reporting. So probably, again, not extremely accurate, but roughly thought to be around about 10% globally. Further into the burden, one must look at morbidity and mortality associated with the preterm birth. And what we do know that a preterm birth is the leading direct cause of neonatal death. And this occurs in about 35% of those that are actually born less than 28 weeks of pregnancy. Also, just to underscore the importance of this topic, it is actually the second leading cause of under 5 child mortality. So if we look at all under 5 child mortality, 18% of that is actually due to children being born at less than 28 weeks. And if we look at an annual figure, this is roughly about 1 million children or infants that are lost every year from this condition. So it has a major impact on individuals and societies. So again, most of the data coming from high-income countries where there is reporting and measures in place to track this sort of disease, pathology, is that we know that in around about 2015, premature infants accounted for about half, 8.4 billion of hospital charges for all infants. So you can imagine that these most, if not all of them, need either admission into a high care or a neonatal facility, which means bed occupancy, which means medications, which usually come at high cost, many investigations, long stays, and it does not end at that point. It then means, again, repeated hospital visits for many of these children with really high demands on resources. So, we've spoken about the burden of mortality, and we've spoken about the burden on resources. But also along with it comes this almost sort of hidden burden, which is that of
Est-ce que tu peux ouvrir le
morbidity.
link là?
And many a time
Je viens,
people
je viens
have
d'envoyer le
this
link.
false belief that if babies are born beyond 34 weeks, or if they have been born having received corticosteroids
Je ne
and
suis pas en
perhaps
train de
magnesium
présenter.
sulfate,
Je suis.
that the outcomes are fairly much close to that of term, and that's not true. And that is because, despite the fact that these medications, which are
Je
very
viens de
much
t'envoyer le
changing
link
the face of
Zoom.
way we treat and look at preterm birth, they do not equate to complete maturity of the baby. So there are various organ systems that need development and maturation, which is best achieved in most circumstances in utero. So much of the morbidity related to this can be described on the headings that are listed there, which I will not specifically read out or go through, but you can see that they are multi-system issues, and they're not necessarily acute. They can continue into the long term, and some of them even well into adulthood. So very important to know this and keep this in mind. So when we think about the burdens, and those are the ones that I have actually mentioned, are things equal? And clearly what we know is that unfortunately it is not equal. And like many other conditions, low and middle income countries and resource constrained settings are disproportionately affected, again, by preterm birth, by infection, by morbidity, higher rates of morbidity and mortality. We know that the highest rates of preterm birth occur in low and middle income countries, and they roughly account for approximately 90% of all preterm births. And associated with that, and perhaps linked to the socioeconomic circumstances of being born and living in a low and middle income country, unfortunately, it is also associated with the highest mortality and morbidity rates. So looking at the world map and looking at the rates of preterm birth, you can clearly see that the areas that are most affected lie in much of the African continent, in parts of Asia, and in parts of South America. So if you are interested, there is a very nice article that you can actually refer to that actually very much describes what is the issue and how does it affect low and middle income countries. Okay. So our next question is, why does preterm birth occur? So preterm birth can occur either spontaneously, or it can be an iatrogenic preterm birth, or otherwise an indicated preterm birth. And what basically we mean there is in the iatrogenic is that we actually put in some intervention to deliver the baby at an earlier gestation because we consider the ongoing pregnancy to be unsafe for either the mother or the baby, or for actually both of them. Common conditions in which we see this would be conditions like preeclampsia and fetal growth restriction. And these roughly account for about 1/3 of all preterm births. When we talk about spontaneous preterm birth, these are some sort of factor that has actually led this pregnancy to go into labor much earlier without any active intervention to bring on that labor process from the healthcare worker. So when we look at the spontaneous preterm labor, which will really be much of the focus of the rest of my talk, you will see that it is currently considered to be a syndrome because it is of multifactorial etiology. And we think that generally there's more than one factor involved, and this may lead to a common pathway. And generally, the end results either result in some form of either infection or inflammatory process, which actually gets the cascade moving towards that of a preterm delivery. So there are a whole host of factors, and you can see listed in this, and probably the one that most affects us being in a low and middle income country, and perhaps those that work in state sector hospitals, would be infective pathology, and it's probably the one we look out for the most, and we probably also need to put in some intervention for. But having said that, there's no less other risk factors like vascular disorders, issues surrounding the decidua, conditions in which the uterus is overdistended, things like polyhydramnios, multiple fetal pregnancies, where we know that that many of them are linked to preterm labor, especially in the higher order multiple pregnancies. There's definitely the issue of cervical disease, conditions in which there's breakdown of the maternal fetal tolerance system, and then obviously at the end of the day we may look at everything and come up with the fact that perhaps we really don't know much about it. So what do we have, and what can we focus on to prevent preterm birth? Because ideally that is exactly where we need to start with any sort of condition. So this is actually comes from the Saving Babies' Lives, and it is actually produced in the United Kingdom, and it actually speaks about a care bundle. And for those of you who probably work in obstetrics know that actually the bundles have nowadays proven very effective in many of the fields of obstetrics, and bundling these specific interventions and actions together has led to significant improvements in the way we manage these pregnancies. So they basically break this up into the team and then measures to take into prediction, prevention, and perinatal optimization of the pregnancy. So in terms of prediction, all women should actually be assessed at the very first antenatal risk visit for any risk factor that may actually be present for preterm birth. And then they should subsequently be directed into the specific clinics where they may receive the necessary attention that they require. In terms of prevention, and extremely important for more than one reason, would be issues around smoking cessation. In terms of looking at the indicated or iatrogenic preterm deliveries, is identifying patients that are at high risk of developing preeclampsia and then starting low-dose aspirin at the appropriate gestational age, making sure that there's a chain of continuity of care. Then comes things of considering already in the patients that you have screened regarding some sort of intervention, which I will elaborate on further, including cyclage, progesterone, or pessary, placing patients in correct clinics, and then surveillance of those. And your perinatal optimization looks at all the interventions once the patient actually does present with the conditions, which includes is the patient in the correct place where it has all the necessary resources to be born, have we administered the correct medications, and what sort of cares and interventions are in place for management of the birth, the delivery, and the postpartum period. So there are certain risk factors that are highlighted that need to be addressed in all pregnant women. And smoking, apart from just preterm birth, we know has adverse effects on many other areas of personal health and that of pregnancy. So when we look at smoking and preterm birth, we know that it actually doubles the risk of preterm birth. And there should be, apart from just attempting to tell the patient to stop smoking, there should be systems in place to assist the patient with actively smoking, stopping smoking. And on that note, generally, and from many reports, pregnancy drives many women to be highly motivated to do what is best for their unborn child. So it may just be some gentle motivation, and some others may need further support, but it is definitely something that is and can be done. Maternal age, again, the extremes of age. We know that in the very young, risk of preterm labor is high, and it is associated with multiple factors, including the association of probably promiscuous behavior, infections, the kind of link between that and certain alcohol, smoking, drugs, etc. And on the other extreme of age would be those over the age of 40 years, where there may be other comorbid conditions that need to be specifically looked at and screened for. Domestic violence should not be forgotten about, and this needs to be actively spoken about at the antenatal visit, and patients at high risk may need to be referred to specific support services. Asymptomatic bacteriuria, and generally this is not an issue, but yes, in pregnancy and the known physiological changes that occur in pregnancy, we know that asymptomatic bacteriuria is a problem that can lead into a significant number of patients into a full urinary tract infection and worse, of pyelonephritis. And about 20 to 50% of patients who have had an episode of pyelonephritis can actually go on to deliver preterm. Therefore, we would suggest that at the booking visit, there's at least one urine sample taken for microscopy, sensitivity, and culture, and basically to identify those at risk and treat. Women should be asked about any sort of vaginal infections and treated appropriately for those, because again, that's a risk factor for preterm birth. So we then look at a smaller group of patients where we can identify certain risk factors that place them at higher risk of preterm birth, and probably the one that screams out the loudest and probably carries the highest weight in terms of risk for a recurrent preterm birth would be a previous preterm birth or mid-trimester loss. So that is a flag, and those patients automatically should be in the right place where they can receive the proper surveillance and intervention. Previous preterm pre-labor rupture of membranes, less than 34 weeks of pregnancy. If a patient has had a cerclage in a previous pregnancy, patients with known uterine anomalies, patients diagnosed with intrauterine adhesions. And fortunately, we don't have many, but if a patient has undergone a trachelectomy, which which is removal of the entire cervix, but with uterine conservation for cervical cancer, then those patients are extremely high risk and actually should have a prophylactic cerclage placed in situ. So what are intermediate risk factors? So intermediate risk factors are considered to be a patient who's had a previous birth by cesarean section at full dilatation. And another immediate risk factor would be where there is some sort of cervical excision event, so something large loop excision of the transformation zone for the non-invasive malignancies of the cervix. or they've carried out a cone biopsy, they are considered to be the intermediate risk of a preterm birth. So what sort of surveillance should we be putting in? So I just highlighted this a little bit because truly it's not really surveillance. It's actually where we need to intervene. But if we have a patient with multiple previous preterm births or trimester 2 miscarriages, so these should actually be consistent with a history or with a history that is suggestive of cervical incompetence. These are not iatrogenic preterm deliveries. These are not your typical miscarriages. So typically what we would expect with a history with is painless painless contractions or rupture of membranes and rapid delivery of a fetus. So ideally, these women should be identified, and these are patients who we should actually see for a preconception consultation, because there is a possibility where we could work them up and consider them for a transabdominal cerclage in the pre-pregnancy period. And the reason why we could consider this is obviously the risk is the lowest for the fetus, as there is no fetus in the pre-pregnancy period, whereas if we do this in pregnancy, the risk is there for a potential miscarriage. So what about the patients that are high risk? And it is the factors that I've mentioned before. So in those patients, we actually put in a cervical surveillance program, and we offer transvaginal cervical length scans every 2 to 4 weeks. And in our setting, it's actually 2 weeks that we do them, between 16 and 24 weeks. And what we're actually looking for in these patients is cervical shortening, which would be considered a cervical length of less than 25 millimeters, at which point we know that we need to put in an intervention. So it's extremely important, and for those who use maternity care records, we use the gravidogram to actually record the cervical length at each cervical scan, so we have some sort of idea about what is the trajectory of the cervical length. In terms of the intermediate risk, they will also need further risk assessment, and in those we will offer a single transvaginal cervical length scan, and this is typically done at the time of the fetal anatomical survey, which is a scan done at roughly between 18 and 22 weeks of pregnancy. And should that cervical length then be short, then an intervention may be put in place. What are the interventions that we have and know about? We have progesterone, which are typically 200 milligram vaginal capsules that are used every night from about 16 to 34 weeks, sometimes a bit longer. We have cervical cerclage, which is essentially a suture that is placed around the cervix. And this can be actually placed in many ways. It can be placed transabdominally, and this is actually by either laparoscopy or a laparotomy. We can have transvaginal methods in which the sutures can be placed. And this is actually to reinforce the cervix, keeping it closed, maintaining the mucus plug, which is essential for a pregnancy ongoing. In terms of cerclages, when we decide to do them, can either be history indicated. So the patient's history tells us that there is sufficient evidence in the history that this patient requires a cerclage. This is a cerclage that's typically done early in the pregnancy. We have an ultrasound indicated cerclage in which we've done surveillance of the cervix and have now found a short cervix, and that then indicates a cerclage. And we have emergent cerclage, which is actually really done under emergency circumstances. And the one that is probably less known about and probably less used is the Arabin pessary, and basically kind of works on a similar sort of way as a cerclage. And it's basically this device which appears there that can be placed through and around the cervix to support it through the pregnancy. I'm not going to speak much about it because we don't really have it available quite widely, and the probably more used is progesterone and cyclage. So who should we be using progesterone on? So it can be used prophylactically in patients with a history of spontaneous preterm birth or a second trimester miscarriage suggestive of cervical incompetence, or if they have another risk factor for preterm birth. As mentioned previously, we can also have ultrasound indicated. So the patient in which we have done a cervical length now is less than 25 millimeters, either in the serial surveillance or in those that qualified for a single assessment at mid-gestation. And we do know, and earlier on some of the literature did come up, that vaginal progesterone reduced preterm birth rates below 34 weeks by 20% in patients who have previously had a preterm birth or a short cervix. So important to know. Cyclage. So the history indicated, as I said, is a prophylactic measure. In this particular patient, it is the history that solely indicates the need for a cyclage. You do not need to have a short cervix. Generally a mixture of either 3 or more previous preterm births or mid-trimester miscarriages. And these women are generally asymptomatic. It is usually put at a planned procedure at about 11 to 14 weeks after we have made sure that we have put in at least some sort of method to ensure we have a, within the limits of a first trimester scan, a structurally normal fetus. An ultrasound indicated cyclage is a therapeutic measure, and it is in women with high risk of preterm birth, and is here where we have found the cervical length less than 25 millimeters. So we have both preterm birth and cervical length less than 25 millimeters. They mostly are asymptomatic, and in these patients, the amniotic membranes are not exposed to the vagina. So this is usually done between 14 and 24 weeks, again after having done what we can to exclude any lethal or severe fetal anomaly. An emergency cyclage is, as it says, a cyclage that is performed mostly as a salvage measure, and it is in patients who mostly are asymptomatic of their cervical dilatation, may present usually with some heavy sensation and vaginal discharge or some vaginal spotting, and then it is found that the cervix is dilated and the fetal membranes exposed into the vagina, but not beyond the introitus or more cervical dilatation beyond 4 centimeters. It can be done up to about 26 weeks, however, there is literature to say that it can actually even be done further. So the question, and this is a topic that has evolved rather rapidly recently, is what about twin pregnancies? Yes, we now know that there is a role for transvaginal cervical length measurement in the mid-trimester in twin pregnancies. So it is recommended, and if you are able to do it, it should be done. Vaginal progesterone significantly reduces the risk of preterm birth occurring at early gestational ages, neonatal morbidity and mortality, and very low birth weight in women with twin gestation and a sonographic short cervix of less than or equal to 25 millimeters. What about cyclage? Well, that has fewer studies, but definitely has shown that there is a trend to improvement in preterm deliveries in patients who have a very short cervical length, less than 15 millimeters, or dilatation of the cervix. So unfortunately, we are looking and waiting for more randomized control trials. The literature currently is mostly observational, and some of the data is quite dated and of very small numbers, but definitely a trend, and each case needs to actually be assessed on its own accord. So there may still actually be room in very short cervices or in dilated cervixes in multiple pregnancies to actually offer a cerclage. Diagnosis of preterm labor, I think many may know, we want to know that there's regular uterine contractions, there's progressive cervical dilatation and or effacement prior to 37 completed weeks. It is a clinical diagnosis. However, more and more ultrasound is being used as a measure to assess cervical length and dilatation. The very big problem thus far in our diagnosis of preterm labor, it is not very sensitive or specific. And unfortunately, the vast majority of women that we come to the diagnosis of preterm labor will not go on to deliver preterm. So at the moment, and Pumza will tell you about exciting other things like biomarkers, that may actually help us refine our diagnosis and decide who needs admission, who needs steroids, who needs magnesium sulfate, etc. So what should we do? We should identify and manage precipitating factors, specifically looking at things like infections, things like polyhydramnios, trying to actively look out for what actually is leading to it. If there's no contraindications, and then you should also decide what your local fetal viability criteria is when making such decisions. You should consider tocolysis, corticosteroids, and magnesium sulfate, and this you should again follow local protocols. You should ensure that the patient is at a facility where the necessary resources are present to manage the patient and to manage that of a preterm neonate. If the delivery does occur, it is recommended that one practice delayed cord clamping, that the placenta is sent for histopathological assessment. Again, this will depend on your local protocol and your resources. We should ensure that the baby is kept normothermic in our settings.
Recording in progress. What am I supposed to be doing? What am I
Bags
supposed to be asking
and
for?
with
What can I ask?
woolen
So
caps
these
to
buttons
make sure that
will
they are
help your
kept
user
normothermic
identify
during the
how to
transfer,
use your GPT
and
or
we should
what
aim for maternal
questions
breastfeeding
it
within
could
6 hours.
or should ask. So this is where you can add in all of these buttons. And of course, some of these are linked to forms, like your AI agent knows to kick off things, which I'll show you here in a little bit. And then of course we have the menu. You can't really see it, but it's whenever you click on this little hamburger menu right here, and we'll be able to see more of this when we go into full screen. But if you want, you can turn off the voice option. You can turn off them being able to see the forms. You have the ability to turn off and on lots of different options. Okay, so let's go ahead and go into the designer, that little paint roller. So this is very similar to JotForm Form Builder. So right now we're going to land in the gallery for our avatar. So this is where we can change the way that your avatar looks. You can see you can choose from a lot of different people, and it'll just keep going. You have options for mascots as well. If you want, we can even come in here wearing a red uniform. Let's see, holding a phone. So let's see what this gives me. A lot of times I would come in here and I would just say, just change it to a red uniform. It would change the gender. It would change the entire thing. So that's why I put female, and I want to change what she is holding to be a phone. So you can see that you can literally type in whatever you want. Now, another thing too is on that next tab, the upload tab, if you want, you can upload a photo of maybe you, or maybe whoever the face of your brand is, or maybe it's a mascot. You can upload that, and that can be your avatar. So you can see we have female, change it to red, now she's holding a phone. So I'm gonna go back because I like this version of Julie. I'm gonna keep it on her. Another thing that is really fun is down here at the bottom, we have what's called face swap. So on one of my GPTs, or one of my AI agents, I utilized this girl because I feel like she looks kind of like me, and then I use the face swap, so it takes one of my pictures and puts my face on her. So it kind of looks like me, and it has my face. It's AI, you know, it's fun. So if you want to try that, definitely give that a try. It's kind of fun to see what that looks like. And then we have the style. This is when you can change the overall color scheme of your AI agent. We have this section right by here. We have the start color, the in color. You can see it's kind of like an ombre effect. We have the agent title, which is this right here. You can also change her name and her role here. We can also change that over in the train tab. We have the page background, which is going to be this right back here. Again, you can kind of see I have it as an ombre. If you want, you can upload a background image. You can generate like cozy coffee shop, vibrant tattoo studio. You can type something in. Then we have the chat style. This is going to be right over here where this is. We can change the font family. The button is going to be right down here. So I want to change that button color. We can make it maybe hot pink. And then we can change Julie to be on the other side if we want. Now down here at the bottom is the logo. If you would prefer something different to be right over here instead of your avatar space, you can have a logo there instead. Okay, so once you have finished your designer up here in the standalone, now I would kind of go through and look at what the other ones look like, because chatbot for sure, depending on the colors that you choose, you could have an accessibility issue up here. So choose standalone first and then come over here and look. But all of these other ones are going to look how they're going to look in their native space. So this looks like Gmail. So of course it's going to be a phone, like text, like WhatsApp. All these are going to look how you would assume they would look. Presentation is really, really neat. This is what came out last month. So if you have a presentation, like a slide deck, but you don't have maybe like the notes for it, or you don't have a voiceover for it, you can upload it into your presentation agent, and your presentation will give you a script, and they will also voice over for you. Now, if you have an idea for a slideshow, for a presentation, I'm going to jump over to publish and show you. So this one right here, the Elegant Wedding Venue, this one is completely generated by AI. All I did was tell it what I want. Like I wanted, our hotel offers weddings. I wanted to do a presentation for it, and it put this entire thing together for me. And let's see. So you can see like there's a script, so that's what they're going to talk about. And when we get to the end, I'll kind of show you what that looks like as well. Okay, that is it as far as the build tab go. So I'm going to go over to the next tab, which is going to be train. And this is where you're going to give your AI agent everything it needs in order to be successful for you. So as you can see, it puts us in the knowledge base, but we can always go one tab up, which is going to be the AI persona. This is going to be the second place where you can change your AI agent's name, and it gives you some suggestions as well. We have the default language. So one question I actually get is, can my AI agent support multiple languages? As of right now, it can only do one language at a time. So what I would suggest is you get one agent completely how you want it to be, and then you can clone it from your workspace dashboard. You can clone that agent, come in here and change the default language to whatever other language you would like. You can change the tone of voice. You can also change the length that they're going to respond. You can choose between the chat, the voice, and the email. You can choose from minimal all the way up to chatty, completely up to you. These chat line guidelines are also AI generated, so make sure you check these. You can also add new. So here you see suggested. You provide clear and concise answers. You can type in whatever you want. If you don't want any of these, you can easily get rid of them. Super simple. You can see here. This is one place where you can change your agent's voice. There's other places that we can do that, which I will show you. And then of course, all right. Next down is going to be the knowledge base. Again, this is where you give it all the things that you want. Because I do add a new knowledge base. It's so funny. Every time I come in here, there is something added. So last week I came in, these two were added, YouTube and Zendesk. And this week's Fresh Desk is something that is new. When we launched, we just had these top four. So the first one is going to be knowledge. specified pages. So let's say I want, of course, jobs.com, and then I want /security, /contact, /FAQ, /about us. I get to choose which pages I want it to look at and pull from, and then I would just go from there. Keep in mind, every single character on those pages is going to go towards that character limit. So if you're going to use this, keep that in mind. All right, next up is a file. So if you have a PDF, manual, a document, PowerPoint, anything that is a file, you can upload it in here. You can tell your agent how you want to use it. And then you have Q&A. So if you have very specific questions that you are always getting asked, you can put one question in here at a time. So for example, whenever I first originally created Julie, within the website, the link that I gave it, it tells you how far away the Golden Gate Bridge is from the hotel. But when I asked my agent, it didn't know the answer. So when your agent doesn't know an answer to something, it's going to land right here, and it's going to look, wait, back one more. Where is my knowledge base? Well, I guess it's going to land right here, Q&A. See, even this looks different, because normally it would give like the whole list of everything, but it's kind of consolidated. It ended up being Q&A, and it's not going to show me what those Q&As are. It'll be red, and it'll have a red X, and it'll say your agent didn't know how to answer this. And you'll also get an email, so you will know. And it said, we don't know how to answer this question. So I literally answered the question, how far away is the Golden Gate Bridge from the hotel? So not every time someone asks that question, it answers it without missing a beat. Okay, then of course, if you have a YouTube channel, you can add your channel, specific videos. And of course, if you use Zendesk, you can add in Zendesk, your knowledge base. And then of course, Freshdesk, you can enter your subdomain. Pretty neat. So if you already have knowledge base in those places, might as well use that. All right, next down is going to be actions. This is going to be similar to conditional logic in the form builder. So if this, then that. So if I want to add a new action, it's best to leave it on all channels just in case you decide to share it in other places. But you can see it's all those channels that were over on the left-hand side of the screen earlier. So when the conversation starts, when a user asks about, talks about, when they provide, when the sentence contains, you get to choose what that looks like. And then what do you want it to do? Do you want to start the form filling process? You always want to include, you want to not mention.
Funneling and sludge is also often considered together with cervical length and can help to improve the diagnostic and predictive capability of cervical length, but if they're used alone in isolation, they're not as reliable as markers. The rest of the markers that are listed here, they're largely investigational, or the ones that have been used in clinical practice. It's usually used in smaller units, high income setting, and units that are MFM-led because they do require specific software and specific expertise to be performed. And then lastly, there's also other new novel investigational tools that are still largely in the infancy stage in terms of research, but probably one of the ones that are growing in that stage is the vaginal microbiome. And Sam has already mentioned that one of the largest leading causes of spontaneous preterm birth is infection-related causes. Next slide, please.
And the AI agent can help your users shop. So like you're in talking with it, they can say, hey, I want
so the other thing that we need to consider when we talk about tools to predict spontaneous preterm birth is combination tools. And physiologically, that might seem to make more sense. And we think that it might improve predictive ability of testing. So one of the tools that's currently available to us in clinical practice is an app that is known as the Cook app. This app was developed and validated in the UK. And essentially, the app combines three things: patient's clinical risk factors and the cervical length and quantitative fetal fibronectin. And we know that the test performance is improved by fibronectin. Biopsies can still be performed and can still give you a prediction without fibronectin. So it's quite easy, and the app is free to download, and it is being used in the UK. And what it does is, after you generate
answer the question of what, and
individualized
then
risk score
offer
for that
for them to watch
specific
the
patient.
presentation. So let's
And
watch
then
that.
a risk of more than 5%
You know what?
for traditional
So
within
someone
1
asked
week
if
is
they
considered
connected a link in
significant.
LinkedIn.
And then generally
I
it
don't
is
think that
advised
would
that
be.
in these patients we may consider
That isn't
interventions
yet.
such as steroids or steroid treatment. But I think the most important caveat in do saying that the app is meant to be used as a tool to assist clinical acumen and is not necessarily used as a goal. Next slide, please. So we know that there are many options, but with these options there are important limitations. And these limitations include things like cost, expertise, availability of specialized equipment, but probably the next 2 points are the most important for our setting is that these tools still lack that desired time frame of predicting delivery within 7 days, which is important for treatment interventions. And also, these treatment tools or the diagnostic tools have not necessarily been validated in low middle income settings, so we're not really sure about their relevance and their generalizability in our setting. So with that in the background, then we need to consider what would be the ideal test. And then a group that published an article last year in the Frontiers Medicine Journal, they described that the ideal test should be one that is precise and accurate, and in this setting, one that is accurate to predict time to delivery within 7 days. It should be a test that allows for point-of-care testing with an easy learning curve, and it should be a test that has been validated in a variety of settings. Next slide, please. So if we come back and think about what we're doing locally, so for the management of preterm labor, we have the national guidelines that give us some recommendations to follow. We also have the Better Odds guidelines from SASOL, and then we have local hospital protocols. And in clinical practice, what we end up using is history taking, clinical examination, and like I mentioned, transvaginal ultrasound, but still this is largely limited to the asymptomatic population. So this brings me to my study and what we're doing. So as previously mentioned, the study is titled the CASE study, and that stands for Survival Assessment Research. The study will have 2 components. The first part of the study, we're looking at different survival biomarkers and want to compare them and see what is their ability to predict the risk of preterm delivery in symptomatic women that are presenting to the hospital. The second part of the study will be a national survey. I see Sam has come on. I'm not sure if she's reminding me of my time limit. I'm almost done. So the second part of the study will be a national survey, and in the survey we'll be essentially assessing what is the current local practice in the management of preterm labor. Next slide, please. So just to describe more the first part of the study, and we've currently we started recruiting patients from the beginning of March this year. We recruit from the antenatal ward or labor ward. If this is any patient that is admitted with a concern or threat of preterm labor, and this is women between 24 weeks and 36 plus 6. We're recruiting both singletons and multiple pregnancies, but they will be analyzed separately in the final analysis. And we can only include women who are not more than 3 centimeters dilated and without bulging membranes. So they get offered 3 tests. The first test is for the actin test.
Aisha.
You can stay on the slide, it's fine. So the first test is for the actin test, and what it does, it measures phosphorylated IGF-BP1. Then we do a quantitative assessment and a qualitative assessment. So with the qualitative assessment, it's a dipstick test. It gives you a yes or no saliva swab, and then you put it in a reagent, do a dipstick test, and it gives you a yes or no answer. A yes answer being a positive test, and that's associated with an increased risk, and negative answer being a low risk test. But what is new and novel about our study, we also added quantitative values. And this is because from the fetal fibrinogen studies, we learned that it might be more valuable to to do a quantitative assessment because the risk varies according to the different concentrations of the biomarker that you're assessing, meaning that the higher the biomarker level, the higher the risk, and the lower it is, even though the test is positive, the risk might be slightly lower. And both these tests are point-of-care tests. They're easily available. The qualitative test, you get a result in 5 minutes. The quantitative test, you have a result in 15 minutes. The second test assesses cervical stiffness, and the second test is called a prématuré. The device was developed in Switzerland, and this is still an investigational device that obviously requires validation. And the concept of the test is done via speculum examination. There's a single-use probe which is attached to a unit that generates a weak suction. So the probe is passed through the speculum, contacts the anterior cervical lip, and then there's a slip pedal. You press the slip pedal, and then a weak suction is generated, which causes displacement of cervical tissue over a fixed distance, and this distance is about 4 millimeters. Then a number gets spewed out on this machine, and essentially this number is supposed to reflect how soft or how stiff the cervix is. Then the last test that we do is transvaginal ultrasound, where we measure the cervical length, and then we enter the patient's details into the app, and then we get their risk score. So far we've recruited quite a few women, and the results have been quite interesting, and the experience itself has been quite interesting. Next slide, please. Then the second component of the study, this is one that we're still currently busy with drafting the survey, and it still requires HREC approval, so it will only be distributed later on this year. We would really like to have national involvement and really like to have representatives from each province, both in the public sector and in state. And essentially what the survey will evaluate is what are we doing and how we're deciding to manage women with preterm labor. There's going to be 5 components that will be addressed.
Papa, est-ce que ulinita leo? Hein? Hakunita? Sika hakuna info. Maître Bondo ye alisha kumchukia Joseph Kabila, hata misi amchukiaga vile. Maître Bondo ye iko plus que mie, iko na resetting. Mimi naspenda tumu crash, tumufanye share apate, meshue ye anaweza kumfanya nini? Kanamba? Ni munini mule kwa nani, kwa Kubez?
Non, il y avait l'autre procès qui était aujourd'hui.
Procès kwako mishi kuifata, nilikuwa na skula nyumba. Abanipatia kitu kama mimi na skula nyumba. Est-ce que je suis obligé? Donc, uko na me revoir au qu'on a fait un Maître Bondo?
Non, mais je me revois.
Nuko akula bukari ya kipolo na sombe ya moto. Papa, la fille est arrivée en finale, hein? Elle va gagner. Hein? Tu sais, elle joue contre qui? Nikutumia image busubuhi. Elle fait vraiment la fierté des Canadiens. Et Didier Budimbo est en train de dépenser 40 millions au lieu de kufanya maternel tennis. Donc batoto etu kama bigo na maakademi ya tennis ya bien, banaweza kupata na boma million, panaenda kukompetir parce qu'elle l'a prouvé. Elle n'a que 18 ans. Ribakina na souffrir. Donc huyo mtoto ampika Coco Gauff, anampika Ribakina, anampe. Maintenant, elle va aller au Cincinnati. Tu sais, il joue avec qui, Mounani, mon final? Aoyajibu.
Non.
Elle va jouer avec l'ennemi de Serena.
Qui est l'ennemi de Serena?
Naomi Osaka.
C'est deux noirs, hein? C'est deux noirs qui jouent alors.
Est-ce que Naomi anakuwa noir iko japonaise?
Papa qui a Naomi haïtien ou jamaïcain.
Ndio maana anakuwa mu-américain.
Il ne faut pas dire ça parce qu'au Japon, on l'a rejeté aussi.
Mais, malgré tout,
C'est sensible, on n'a rien à passer.
Serena ne l'aime pas. Serena t'a suivre les matchs avec intérêt. Anafataka match yote ya Naomi. Yeye ndio alimfungaka Naomi, sasa anamfungula. Naomi a tout essayé, venait de chasser l'entraîneur français. Njo anaanza sasa kucheza bien. Mais je crois qu'il Serena. Serena sunirumieko. Njibu. Budhram. Mimi nasikia kama Budhram alitokea kwenu. Shunamona Budhram. Alitokea kwenu Sam. Parce que mimi nasikia anasema anakujua. Parce que alitokea kwenu akakuya kunani. C'est elle maintenant la chaire Okwetu Afita médecine. Wasive. Avec moi aussi. Vous avez fait ensemble. Vous avez fait ensemble. Elle maintenant consultante, elle veut faire le PhD. Elle est sur les prématurés.
C'est la fiancée de Sylvie. Sylvie, c'est l'un des aussi, ceux-là qui ont réussi. Il veut faire reproductive medicine.
Elle est maman papa. Nani, PhD. Elle est très gentille. Elle est très aimée par tout le monde. Quand elle écrit ses notes, je pensais toujours à toi. Elle écrit bien mingi. Ndio vile tu na yeye alibaki. Tunaweza consultant na barrage bampenda tu ma résumé et puis tu passes directement. Comme on indique bien mingi. Ba mingi abapenyo.
Maybe the other is maybe a more technical question is after LETS, how safe is the mom's bladder and bowel cyclage?
Mjuleka, Pumza.
how safe is the bladder or bowel receptors? So in other words, does the lead procedure increase the risk of injuring bowel or bladder?
Deborah?
And
No,
I
not that I'm
can't quite,
aware of.
Inanyo?
can't quite conceive it because you would
Parfait, bébé.
done a really aggressive.
Do you mind coming to collect this plate? Yeah.
Yeah, I'm unaware that should actually affect the bowel of the bladder.
I think, sorry, the only way
And a cup
that
of
might
tea.
be possible if
So
there's
cold.
poor visualization and you're cutting
Just
where
tea.
you're not supposed to be cutting, like you're cutting closer to the rectum or whatever, let's say. But generally, no.
Yeah, great, thanks. So still as safe as the surgeon. Eh? Then a question, and this really goes along the upper limit of cyclage. The question is the role of cyclage not to get to viability? And I think that's something one can discuss in itself, but the question, should cyclage still be an option after viability is reached, which the questioner setting in her setting, or he's setting 27 weeks. And, you know, what's the viability of cyclage really in this late period? So maybe just to unpack all that a little bit.
Yeah, I mean, I think first of all, obviously, the aim is to get to viability. And obviously, if we can get beyond viability, every day counts. So I think you can argue around it. First of all, it's knowing what your viability criteria is. So whereas, example, in our setting, where we may say 27 weeks, and our upper limit for placing a cyclage or an emergency cyclage will be 26 weeks, because we think perhaps in that 1 week we will do, if you look at roughly how much time you can buy with an emergency cyclage, some people say on average about 34 days or so, so that does make a significant difference. However, as been mentioned, the later you put the cyclage in, the riskier the procedure becomes. So I think it's got to be a careful way of. I definitely wouldn't see personally the reason if you have gone
YouTube,
past the
c'est mon
viability
channel, no?
criteria of your institution that you should be putting a cyclage in.
Oh, tu sais, c'est
I would
vrai.
definitely think in my mind that it make logical sense that if you have not reached that viability of what is, it's definitely something to consider. But in my opinion, definitely not once you at your viability range. I think at that point, then you need to be considering your other measures should preterm labor occur.
Also, I think it's also important to remember why is the patient going into preterm labor, and should we be prolonging this pregnancy, especially once viability is reached?
Right, thanks. Good. There is a question, I think you piqued the curiosity on the Arabian pessary and how effective it is compared to the cyclages. I think I'm going to pose that question just to say that I think there are big meta-analysis that really cast the role of a cervical pessary into question. And so it's not really all that effective. The way I look at it, it is less effective, and also just, you know, without putting anyone off their dinner, which I hope you haven't had yet, is, you know, it is usually you smell, you can't do a double-blind test because you can actually, well, maybe not blind, but you'll smell out the patient who has the pessary. So I wouldn't, for one, think that we should really campaign to get it locally. Maybe just two quick surgical questions. One is a surgical question, and the other is more an. Can a fibroid be removed during cesarean section?
Sorry, you broke up there a bit slow. Sorry, what was the question?
Okay, so the first question was, are multiple fibroids a cause for preterm labor? And the second one is, can a fibroid be removed during cesarean section?
Do you want to go or shall I go?
There has been an association that has been recognized between multifibroid uterus and preterm labor. And this is from two components. One purely from the stretch mechanism, but also the component of placentation depending where the fibroids are sitting. In terms of, and also the other being that some patients with a history of fibroids may have assisted reproduction, so there's that added factor. In terms of surgery, doing myomectomy and cesarean section, not recommended because it can be quite bloody and it may risk, puts the patient at a significant risk. So I think the important thing there is preoperative planning, because usually you would encounter that situation if it was a fibroid that was undiagnosed and an incision that you didn't plan for, probably peering into an area that has a fibroid. So I think knowing about the fibroids before going to surgery, knowing where they are, planning your laparotomy incision so that you have good enough access, but also planning your uterine incision very carefully after inspecting the uterus, knowing that you're going to have enough room to deliver the baby, but also you'll be able to close and you'll be far enough from that fibroid. And it's usually a catastrophic salvage procedure for you to have to do a myomectomy at cesarean section.
Yeah, I mean, I agree with Pimsa completely. I think even just regarding the risk of preterm delivery, it's the type of fibroid. So, you know, with the submucosal type, you're probably more likely. And whereas if you've got a pedunculated fibroid, yeah, you probably have a minimal risk. And the two main things that she mentioned is placentation around that type, because we expect there to be issues with the placentation, and then just purely the mechanical effect of the fibroid. And then agree completely, we've even had to do an incision in the posterior wall of the uterus to deliver a fetus in a multifibroid uterus, and that just tells you that literally you should do everything in your power to avoid the fibroid, because should you cut through the fibroid, yeah, pretty much exsanguination follows. So I know it's definitely not recommended to plan to remove or do a myomectomy at the time of a cesarean section. The uterus is highly vascular.
It's a bit like forgetting your wedding anniversary, you only do it once. And a question, Sam, for you to comment on the recommendation by ISWAP 2022 that screening with transvaginal ultrasound cervical length at 18 to 23 weeks should be offered to all singleton gestations. And in singleton gestations without previous spontaneous preterm birth, if the cervical length is less than 25 millimeters, vaginal progesterone should be recommended. So your comment on that?
Okay, so I'm going to say yes if you are in a setting where you have the resource that you can do a transvaginal cervical length on every patient, and you can provide progesterone for every patient in which you find a short cervix, then yes, there's enough evidence and literature to support the practice. Personally, we in a very low resource setting with a very large number of patients, we're not able to offer such a service. So unfortunately, it is not something that we have routinely implemented for our patients. However, at the moment, what we can offer is for patients that are deemed at high risk, they will definitely get at least one and perhaps more than one cervical length. But yes, in a high resource setting, enough free staff, enough ultrasound, enough money to provide the progesterone, then I would say there is enough evidence to support it.
Right, thanks, Pumla. I see you also nodding. And of course, that's what guidelines are about. Guidelines are guidelines, they're not straitjackets, so you have to adjust them to your local circumstances. Two last questions. The first one is around the uterocervical angle and how the uterocervical angle determines the risk of preterm birth. At what gestational age would you measure it? How often? And does the pregnancy and pre-pregnancy angle, I would suppose, retroverted to anteverted uterus has an impact? So I think maybe, Pumza, it sounds as though it really fits into your biomarkers. If you want to go first, and then Sam, you can add if you like.
Well, the evidence around the uterocervical angle has been conflicted. Firstly, with studies of similar sizes. On the one hand, they report there is an association with preterm birth, but other groups reporting not really. And also its performance in twins versus singletons, that's also a very controversial area. In terms of the question in terms of how should we be doing it, the routine, there isn't criteria or guidelines that I'm aware of, Sam, in my answer for here, that describe exactly when we should be starting and how often we should be doing it. All that we have is the angle, the acuteness of the angle, or how wide the angle is that could have that association. So Sam, I'm not sure if you're aware of any specific guidance, but I do know that it's not something that's yet practiced routinely also.
Okay, so unfortunately, I cannot say I can quote a guideline because I'm not aware of one myself. And then just, yeah, I mean, going again back to what the literature, it has been described. Unfortunately, the methodology between studies has not been the same. So lots of the times taking different studies with different methodologies and sticking them in one pot and trying to make them sense out of it is quite difficult. And I personally don't think it is reached or at a level where we can say it is a test that can be widely used. I also feel just from a teaching and learning point of view, the question is, can we actually replicate this? What is the inter and intra-observer errors in measuring such an angle? So I think definitely maybe something to look into the future, what comes of it, but really at the moment, for me, not enough, and I'm not aware of any guidelines.
Thanks. And then a role for prophylactic circulage in multiple gestation after a normal first trimester scan?
No.
Thanks. I think we all see no. It's, I think actually good evidence that you are probably doing more harm than good by doing that. And then now really the very last one is just a comment on bladder emptying and cervical.
Bladder emptying and cervical length, yes,
That's
definitely
right.
empty the bladder if you're going to measure the length of the cervix.
Great. All right, good. So that's it all. And I had a couple of questions, but thanks to all the other people who were listening and alert and asking. So thanks again for a wonderful evening. And there are lots of comments as well that say that, brilliant talk, lovely presentations, and I can just add to that. So my heartfelt thanks, Sam and Pumza. Again, thanks to Dalian, who's also helped to put this together, who unfortunately can't be here today. Seems me and her are a little bit out of step, but maybe that's what teamwork looks like. Again, thanks to Alex for making sure our tech support is really brilliant. to MedTalks for hosting this, and MediChallenge for sponsoring all of this, and of course to all of you who are spent an evening listening to us, and I hope you are all the wiser. And if you want to make use of the CPD points through SASWalk, and if you are someone that does scanning pregnant or gynecological patients on a regular basis, go to our website saswalk.org.za and join for a really, really negligible fee. Thanks. Alex, maybe the last word to you. I think you probably have some logistical comments to make as well.
Not that many comments, as a big thank you. Actually, to make a quick reminder regarding the CPD points, that the CPD points are free for SASWalk members. For non-SASWalk members, the CPD points are not free. So the difference is that for SASWalk members, you are required to have a MedTalks profile just so we can actually allocate the points. And for the non-SASWalk members, you are required to have an active MedTalk subscription in order to receive the CPD points for tonight. That's pretty much it for me. A big thank you to all our panelists, to MediChallenge, to SASWalk for what has been very interesting talk and continuing talk series. And we look forward to the next one, which I'm not sure when, but I'm pretty sure once we figure it out, we will let everybody know. So with that all said, that brings the webinar to a close. I will be on for a few minutes if there's any questions for me regarding MedTalks or CPD points, and I will activate the chat. So just need to put your questions into the chat, and I'll read them off and answer them as I see them. Thank you very much.
Thank you.
Thank you.
Utrogestan, the first choice for pregnancy maintenance to make their dreams come true. A recent systematic review and network meta-analysis showed that vaginal progesterone should be the clinical treatment of choice for women with singleton pregnancies who are at high risk of spontaneous preterm birth, and that vaginal progesterone should become the new gold standard comparator. Only vaginal progesterone treatments are strongly associated with reduction in neonatal morbidity and mortality outcomes. This recent systemic review and network meta-analysis concluded that vaginal progesterone is currently the best preterm birth prevention treatment for women with a singleton pregnancy who are asymptomatic but at high risk of preterm birth, and no other treatment can be regarded as superior. The conclusion of this network meta-analysis was further strengthened by FIGO good practice recommendations on progestogens for prevention of preterm delivery, in which daily vaginal progesterone treatment is recommended to prevent preterm birth in asymptomatic women at high risk of preterm birth, either a previous spontaneous preterm birth and/or sonographic short cervix with a singleton gestation. There is no evidence of neurological or developmental benefit or harm in babies whose mothers use progesterone for preterm birth prevention antenatally. Why is the recommendation for daily vaginal progesterone? The EPIC meta-analysis showed that vaginal progesterone reduced the risk of preterm birth before 34 weeks compared with control. Evidence of benefit in reducing preterm birth before 34 weeks was more certain for vaginal progesterone, and evidence for oral progesterone is insufficient to support its use. Overall, a growing body of studies are in agreement in identifying vaginal progesterone as a keystone among the preventive preterm birth strategies in well-defined high-risk categories. Utrogestan, the best choice for pregnancy maintenance. Body-identical progesterone, effective in preventing preterm birth. Safe and targeted delivery to where it is needed more. Trusted by clinicians. Bisan Healthcare, innovating for well-being.
Okay, so I'm going to activate the chat now. Just have to play that. Okay, chat is now activated. Apologies for the delay. Nati, so for the Sassuag members, you are just required to have a MedTalks profile in order to receive the CPD points. So the reason for this is that the HPCSA policies state that you need to get your points through a CPD provider. And by having the profile, we can allocate you the points accurately as well as then upload them to the HPCSA at the beginning of next month. If you do not have a profile now, you have until 12 o'clock tomorrow afternoon. And that goes for non-Sassuag members who need a subscription. You have until 12 o'clock tomorrow afternoon to purchase a subscription. Okay,
so sorry. What time tomorrow?
Got your password. So you'll need to obviously sign into your MedTalks profile. You can go through the forgot password method. So when you go for, say, log in, you say it will be the option which says forgot password, as most sites normally have. Otherwise, I would recommend that you contact Petra at medtalks.co.za as she can assist you with the password reset. So I'll type the answer to your question for everybody to see. There we go. So that is who you need to contact in order to assist with the password reset. So Ariyashi, Shai, sorry, if I'm mispronouncing, you have until 12 o'clock tomorrow afternoon to, if you're a non-Sassuag member, to purchase a MedTalk subscription. If you are a Sassuag member, or if you are a Sassuag member, to have a profile, to register a profile on MedTalks. Registration is free, by the way. Right? I will be staying until about 9:05 for anybody who may have a question for me. But if you don't have any questions for me, you're more than welcome to leave the webinar now and you'll receive the points, as long as you meet the requirements as I previously mentioned.
Infatti possiamo capire il qua con le... Coco Golf Banawi. Anapata ko nani. Consolation. Il y a double. Le double.
Alors, bonjour à tous les amateurs de tennis. Merci d'être là. Nous remettrons maintenant les trophées aux finalistes et aux championnes du double de la 45e édition de l'Omnium Banque Nationale présentée par Rogers. Saluons d'abord les grands responsables du succès de l'Omnium Banque Nationale présenté par Rogers. Tout d'abord, nos chasseurs de balles.
Chasseur de balles.
Les officiels également. Salutations au comité organisateur. Ils s'en viennent. On va les attendre, nos chasseurs de balles. Ils sont tellement indispensables au succès de notre tournoi. Oui, ils méritent une bonne main d'applaudissements. Alors, je vous ai parlé des officiels, je vous ai parlé du comité organisateur. Merci spécial également à tous nos bénévoles. Je vous demande, s'il vous plaît, de saluer les dignitaires qui sont présents avec nous aujourd'hui. D'abord, Nancy Paquet, première vice-présidente à la direction gestion de patrimoine de la Banque nationale. Édith Cloutier, présidente de Rogers Québec. Membre du conseil d'administration de Tennis Canada, José Noiseux. The WTA supervisors with us, Claire Woods. Our WTA chair umpire, Maria Chichak. Popular in Montreal, the volunteer representative, Jean-François Dupuis. Et la directrice du tournoi, Madame Valérie Tétrault. And now, for the trophy presentations, let's have a good round of applause for our runners-up. From China, de la Chine, Zhang Shuai. From the USA, des États-Unis, Taylor Townsend. Ladies, the mic is yours. If you want to have a few words with the fans.
I'll start. Yeah. Who is here? Thank you guys so much. This was truly a beautiful event. This is my first time in Montreal, first time playing this event. So I really had such an amazing time. First, I want to thank my partner, Shuai. This has been so much fun. We've played some amazing tennis over these last couple weeks. We got another tournament to go, so hopefully we get a different result. Coco and McCartney, you guys played amazing. Congratulations for this title. Not so bad to win 1,000. Not playing dumb. John and Shuai's parents, thank you guys for these last couple of weeks. Thank you to the sponsor, Rogers and National Bank. This is really such a beautiful place, and I've truly enjoyed myself. So thank you so much. Merci beaucoup, and we'll see you next year.
Thanks, ladies. J'invite Madame Paquet maintenant. Ms. Paquet will now present the flowers to our runners-up. Et Madame Cloutier remettra maintenant les trophées à nos finalistes. Bravo, mesdames, encore une fois, nos finalistes 2025. Once again, our 2025 runners-up, Zhang Shuai, Taylor Townsend. Maintenant, place à nos championnes. And now, our champions. Please welcome, from the United States of America, McCartney Kessler Coco Golf.
So I want to start by thanking Coco for playing with me this week. We paired up last minute, and so we're laughing now that we played such great tennis the whole tournament. But yeah, congrats to Taylor and Shuai on another great week. You guys both are amazing tennis players. We want to thank the National Bank and Rogers as well, and everyone who helps make this tournament possible, the ball kids, the chair umpires. I hit Jenny a couple days ago, so we want to thank them for sure, and then our amazing team as well.
Yeah, I'd like to thank McCartney for teaming up with me this week and being so clutch. Just 2 tiebreakers back to back. She saved the day, so I appreciate that. And obviously, congratulations to Taylor and Shuai. You both are individually both amazing people and amazing players, and been at the top of the game. And I love you guys so much. So thank you for a great match. And yeah, thank you to our team. Especially JC and McLean. We beat them in tie breaks. I think we're like 4-1 against them, so it definitely prepped us a lot for today. I think this was our 4th match tie break in a row. And then thank you to you guys for coming out and supporting us in doubles final. We really appreciate you. And then, yeah, thank you to everyone who makes this tournament possible, all the ball kids, referees, volunteers, security. Pasquale, he's been the best security guard this week, so I appreciate him. And special thanks to Val and Claire for accommodating us and making these 2 weeks really incredible. So I appreciate what you guys did today. Thank you. And Michael. Oh, our driver, Michael. They want me to thank our driver, Michael. I don't know where he is, but he's been amazing too. He's heard some crazy stories, so I might have to make him sign an NDA or something.
Alors, Madame Cloutier remet les bouquets de fleurs à nos championnes. Et j'invite Madame Paquet à s'avancer pour remettre les trophées à nos championnes 2025.
Le Canada.
Bravo, mesdames, encore une fois, nos championnes 2025 du double de l'Omnium Banque Nationale présentée par Rogers. Des États-Unis, our 2025 doubles champions from the United States of America.
Quand on dit VAT number, donc tu dois mettre ton numéro. Il y a ça.
Great job, ladies. Enjoy. Merci à vous de votre présence. Et je vous dis place aux demi-finales du simple à compter de 18h. Merci d'être avec nous.
ça yo ministre pour avoir fait quoi de spécial? Puisque vous êtes de la politique, je donnerai au service les noms, les regroupements, quelle autorité politique regroupement, sur quelle liste il sera proposé, et puis pourquoi je refuse qu'un sénateur soit nommé. Bon, peut-être Bamoussou Bazali, mais celui-là, j'ai les noms. Je vais donner même les noms au service. Pour que je ne souhaite pas qu'on revienne sur des histoires, les histoires que nous ne voulons pas. Il reste 3 révélations que je vais vous donner. J'avais prévu pour les tout aujourd'hui. L'émission, ces révélations des HK vont vous choquer. Mais vu le temps, avec Gilles Moulumba, d'ailleurs, c'était prévu que tout ça à 20 minutes, on en a fait 60 avec lui. Donc, je reviens demain. Restez toujours fidèles à l'émission HK Today. C'est une émission qui vous aide. Nous avons pris tout notre risque pour vous aider à provoquer l'amour de ce pays en vous, pour que vous défendre, vous protéger beaucoup, vous pouvez toujours protéger. Que mon Dieu vous garde et vous bénisse. Protégez la RDC avec ses 2 345 000 km². Protégez le président de la République. Ce que je vous dirai peut-être demain va encore beaucoup vous choquer. Ce que je vous dirai peut-être demain va encore beaucoup vous choquer. Vous savez, quand j'arrive jusqu'au niveau de vous dire, protégez le président de la République chaque jour. Moi, ce que je fais, je les protège. Je dénonce tous ceux qui sont dans des petites histoires. Oyekoya et Elanga, j'accepte. Vous aussi, on protège la RDC, on protège ses présidents et protégez aussi les missions. Et en même temps, protégez-moi aussi, puisque la guerre là est transversale. Que Dieu bénisse la RDC. À demain pour le prochain numéro. Et bonne soirée. Au revoir.
Depuis mon enfance, j'ai toujours rêvé grand. Malgré tout ce qui peut subvenir comme difficultés et problèmes de tous bords.
Oncle, non, ça fait bien. Chers amis, s'il vous plaît, j'ai des messages importants que je voulais vous montrer aujourd'hui. Les amis qui vont participer à notre business, conférence Zoom. On a dit qu'on va prendre tout le monde à la fois, mais on fera ces Zooms 3 fois. Donc chaque mois, on le fera pour évaluer, pour voir ceux qui ont mis en pratique les connaissances qu'on va vous donner. C'est samedi à 15h, 14h30, je crois, heure de Kinshasa, donc 21h30, heure de Kinshasa, 21h30, heure de Kinshasa. Les Zooms vont passer. Envoyez-nous seulement les messages. Ou soit, envoyez seulement les messages Zoom. On vous envoie les liens. Et rendez-vous, c'est 21h30 samedi, heure de Kinshasa. Deuxième communiqué. C'est communiqué ici. Enfin, je vous annonce ça. Comme vous pouvez le voir, nous avons finalement mis en pratique la loterie DV pour l'année 2027. Donc, si vous êtes intéressé, voici l'unique numéro. Au continue d'un message, je suis intéressé. Vous écrivez.
Did you use my credit card?
Huh?
Est-ce que tu as utilisé ma carte de crédit?
Come on now, baby, English.
Okay. I'm on my bank account right now, and I don't understand what's happening.
Yeah, I used your credit card the other day.
Why?
You know how, like, when you go to the gym, you work out, you build muscle, you get stronger, and then you do cardio to get more stamina. You have a credit card that's a $20,000 limit that you don't swipe. Your credit card does not know how to be swiped. It's not swipe friendly at all, so I'm using it to build stamina for it.
Look, the 20K is for emergency.
Oh, this swipe was an emergency swipe.
So you're stealing from your wife, that's what you're saying?
How you steal from your wife? You my wife. We're together. I cannot steal from you. Just like anytime you take my car to go somewhere and come back. I don't assume you stole my car.
It's not the same. I'm the woman and you're the man.
See, there you go with that feminist nonsense. Always using the car when it benefits you. What are you talking about? You my woman. We're in a relationship.
When are you going to pay back? Because it's a lot. You took a lot.
Yeah, well, I was going to pay it back before you found out. Since you kind of know now, I feel like we got a little more room to breathe. You know what I'm saying? Like, I don't have to pay it right back. Like, we got room. You know what I'm saying? So I'll probably pay it back in like a month.
What did you use it for again?
Emergency.
What was the emergency?
All right, so, your birthday last week? I didn't have no money to get you a gift, so I borrowed your credit card to use it and get you the red bottoms for the gift.
Did you use my credit card?
Let's go, champ. Kick ass. That's what you do. Do it. Cut off the ring. Get it. I'm doing that. Happy birthday. Well, thank you.
All right. Yes. Time for the party now. That's right, baby. Party again. Yeah. Good seeing you, man. All right, baby. Thank you, baby.
Let's go, champ. Get in there and kick ass. That's what you do. Do it. Cut off the ring. Get it. I'm doing that. Happy birthday. Well, thank you.
All right. Yes. Time for the party now. That's right, baby. Party again. Yeah. Good seeing you, man. All right, baby. Thank you, baby.
Let's go, champ.
Didier.
karese bapokiana ya moi nalaki okoseka polele lokola kristal mpe basilonse esukala esika milimo na biso efandaka bebe nanga nalaki okobombama na mipepe makasi libongo libateli mpe masuwa nyonso yebebi titisaka motema bebe nanga nalaki loboko na nga mipepe makasi ekotala na ngai esengo ezali kobengana na illusion na yo bebe nanga
mopepe ezali koningana mpema ya sika mpe koningana malobango ezali kokatata na mokerle mona na nsima ezali kobima mbangumbango kerle mona miso ekanami moko na mosusu kerle mona mitema ebili
yo bebe nanga mbilaka ya bolingo makasi koleka tango bebe nanga ezali bokangami oyo emonanaka te nepesaka biso esengo bebe na ngai bazali ngai esengo ezangi suka mwana na ngai ekomamaki na mitema na biso esangani mpona libela bebe na nga mopepe ezali koninga na pema ya sika mpe koningana
maloba mo ezali kokaka te na moker de mona masina ezali kobima mbangombango ker de mona miso etanga miboko na mosusu ker de mona mitema ebili kasi koleka malobanda ya lokambo ezali na mosala bolingo nde mitema na biso ambatelaka kitoko koleka ezali otobimisi likolo nyonso na bolingo nizipakata mokete mopepe ezali koninga na mpema ya sika mpe koningana maloba mo ezali kokaka te na boker de mona masina ezali kobima mbangombango ker de mona miso ekangami moko na mosusu ker de mona mitema ebili mopepe ezali koninga na mpema ya sika mpe koningana maloba mo ezali kokaka te na boker de mona nasina ezali kobima mbangombango ker de mona miso ekangami moko na mosusu ker de mona mitema ebili kema ebili ker de mona
Ferregola et Barbara Kanami. Rumba 3.0.
nalaki yo kongenga ya mizoto ya butu mwa ezali kokarese bapokiana ya moi nalaki okoseka polele lokola kristal mpe basilonse esukala esika milimo na biso efandaka bebe nanga nalaki yo kobombamanga mipepe makasi libonga libateli mpe masuwa nyonso ya bebe titisaka motema bebe nanga nalaki yo loboko nanga mipepe makasi ekotala na ngai ya sembo ezali kobengana baillusion na yo bebe nanga
mopepe ezali koninga na mpema ya sika mpe koningana
ba illusion na yo bebe nanga mbilaka ya bolingo makasi koleka tango bebe nanga ezali bokangami oyo emonanaka te nde epesaka biso esengo bebe na ngai bazali ngai esengo oyo ezangi suka mwana na ngai ekoma makina mitema na biso esangani mpona libela bebe nanga mopepe ezali koningana pema ya sika mpe koningana
maloba mo ezali kokaka tala moker de mona masime ezali kobeba mbangombango per de mona miso ekangami moko na mosusu per de mona nitemedili kasi koleka malobanda ya lokambo ezali na mosala bolingo nde mitema na biso ambatelaka kitoko koleka ezali otobimisi mikolo nyonso na bolingo nizipaka ta mokete mopepe ezali koningana mpema ya sika mpe koningana maloba yango ezali kokaka tala koker de mona nasina ezali kobima mbangumbangu ker de mona miso ekangami moko na mosusu ker de mona mitema ebimi mopepe ezali koningana mpema ya sika mpe koningana maloba yango ezali kokaka tala koker de mona nasina ezali kobima mbangumbangu ker de mona miso ekangami moko na mosusu ker de mona mitema ebimi ker de mona.
Avec tous les outils vous avez besoin des nouveaux endroits ouverts par la licence immédiate. Veillons à ce que vous ayez toujours plus de réaliser votre prochain chef-d'œuvre. Alors, rendez-vous sur la liste là et commencez à créer sans limite. Bon, encore une fois, bonne chance.
Ferregola et Barbara Kanami. Rumba 3.0.
nalaki yo kongenga ya mizoto ya butu moi ezali kokarese bamokiana ya moi nalaki okoseka polele lokola kristal mpe basilonse esukala esika milimo na biso efandaka ebendanga nalaki yo kobombama na mipepe makasi libonga libateli mpe masuwa nyonso yebebi titisaka motema nalaki yo loboko nanga mipepe makasi ekotala na ngai ya sembo oyo ezali kobenga na baillusion na yo
mopepe ezali koningana mpema ya sika
kobengana ba illusion na yo bebe nanga mbilaka ya bolingo makasi koleka kango bebe nanga ezali bokanga mio ye monana katende pesaka biso esengo bebe na ngai bazali na esengo ezangi suka mwana na ngai ekoma makina mitema na bisesangani mpona libela bebe nanga mopepe ezali kolingana mpema ya sika mpe kolingana
Maluba ezali kokaka tala cœur de mona masime ezali kobima mbangumbango cœur de mona miso etanga miloko na mosusu cœur de mona mitema ebili kasi koleka maloba na ya lokambo ezali na mosala bolingo nde mitema na biso ambatelaka kitoko koleka ezali otodimisi likolo nyonso na bolingo mizipaka ta mokete mopepe ezali koningana mpema ya sika mpe koningana malobango ezali kokaka tala cœur de mona nasime ezali kobima mbangumbangu cœur de mona miso ekangami moko na mosusu cœur de mona mitema ebimi mopepe ezali koningana mpema ya sika mpe koningana malobango ezali kokaka tala cœur de mona nasime ezali kobima mbangumbangu cœur de mona miso ekangami moko na mosusu cœur de mona mitema ebimi cœur de mona
Ferregola et Barbara Kanami. Rumba 3.0.
nalaki yo kongenga ya mizoto ya butu moi ezali kokarese bapokeana ya moi nalaki okoseka polele lokola kristal mpe basilonse esukala esika milimo na biso efandaka bebe nanga nalaki yo kobomama na mipepe makasi libonga libateli mpe masuwa nyonso yebebi titisaka motema bebe nanga nalaki yo loboko nanga lipepe makasi ekotala na ngai ya sembo oyo ezali kobengana baillusion na yo bebe nanga
mopepe ezali koningana mpema
Ferregola et Barbara Kanami. Rumba 3.0.
Nalaki yo kongenga ya mizoto ya butu. Moi ezali kokarese bapokiana ya moi. Nalaki yo koseka polele lokola cristal. Beba silence esukala esika milimo na biso efandaka bebe nanga nalaki yo kobombama na bipepe makasi bebe nanga libonga libateli mpe masuwa nyonso ya bebe titisaka motema bebe nanga nalaki yo loboko nanga bipepe makasi bebe nanga ekotala na ngai ya sembo ezali kobengana baillusion na yo bebe nanga
mopapa ezali koningana mpema ya sika mpe koningana malobango ezali kokakata na kokerbe mona na nsima ezali kobima mbangumbango kerbe mona miso ekangami moko na mosusu kerbe mona mitema bi
nalaki yo kobombama na mipepe makasi libongo elibateli mpe masuwa nyonso ya bebe kitisaka motema bebe nanga nalaki yo loboko nanga mipepe makasi ekotala na ngai ya sembo ezali kobengana baillusion na yo bebe nanga mbilaka oya bolingo makasi koleka tango bebe na ngai ezali kokangami oyo emonanaka te nde epesaka biso esengo bebe na ngai bazali ngai esengo oyo ezangi suka mwana na ngai ekomamaki na mitema na biso esangani mpona libela bebe na ngai mopepe ezali koningana mpema ya sika mpe koningana
malobango ezali kokakata na kokerde mona na nsima ezali kobima mbangumbango kerde mona miso ekangami moko na mosusu kerde mona mitema ebili kasi koleka malobanda ya lokambo ezali na mosala bolingo nde mitema na biso ambatelaka kitoko koleka ezali otobimisi mikolo nyonso na bolingo nizipaka ta moke te mopepe ezali koningana mpema ya sika mpe koningana malobango ezali kokakata na kokerde mona na nsima ezali kobima mbangumbangu kerde mona miso ekangami moko na mosusu kerde mona mitema ebimi mopepe ezali koningana mpema ya sika mpe koningana malobango ezali kokakata na kokerde mona na nsima ezali kobima mbangumbangu kerde mona miso ekangami moko na mosusu kerde mona mitema ebimi kerde mona
Ferregola et Barbara Kanami. Rumba 3.0.
Nalaki yo kongenga ya mizoto ya butu. Moi ezali kokarese bapokiana ya moi. Nalaki okoseka polele lokola cristal. Beba silence esukala esika milimo na biso efandaka. Bebe nanga. Nalaki yo kobombama na mipepe makasi. Libonga libateli mpe masuwa nyonso ya bebe titisaka motema. Bebe nanga. Nalaki yo loboko nanga mipepe makasi. Ekotala na ngai ya sembo ezali kobenga na baillusion na yo. Bebe nanga.
Mopepe ezali koningana mpema ya sika mpe koningana. Malobango ezali kokakata na kokarde mona. Na nsima ezali kobima mbangumbango karde mona. Miso ekanga mimoko na mosusu karde mona. Mitema ebi.
Nalaki yo kobombama na mipepe makasi. Libongo elibateli mpe masuwa nyonso ya bebe titisaka motema. Bebe nanga. Nalaki yo loboko nanga mipepe makasi. Ekotala na ngai ya sembo ezali kobenga na baillusion na yo. Bebe nanga. Mbilaka ya bolingo makasi koleka tango bebe na ngai. Ezali bokangami oyo emonana katende epesaka biso esengo. Bebe na ngai bazali ngai esengo ezangi suka mwana na ngai. Tekoma makila mitema na biso esangani mpona libela. Bebe na ngai. Mopepe ezali koningana mpema ya sika mpe koningana.
Malobango ezali kokakata na kokerde mona. Na nsima ezali kobima mbangumbango kerde mona. Miso ekanga mimoko na mosusu kerde mona. Mitema ebili. Kasi koleka malobanda ya lokambo ezali na mosala bolingo nde mitema na biso ambatelaka kitoko koleka ezali otobimisi mikolo nyonso na bolingo nizipaka ta moke te. Mopepe ezali koningana mpema ya sika mpe koningana. Malobango ezali kokakata na kokerde mona. Na nsima ezali kobima mbangumbango kerde mona. Miso ekanga mimoko na mosusu kerde mona. Mitema ebimi. Mopepe ezali koningana mpema ya sika mpe koningana. Malobango ezali kokakata na kokerde mona. Na nsima ezali kobima mbangumbango kerde mona. Miso ekanga mimoko na mosusu kerde mona. Mitema ebimi. Kerde mona.